And once you get a cancer, I've got a slide on this later, but so this is very early data, but it's there. So not just the risk of diabetes and heart attacks, which is what most of us are heavy worried about, dying of a heart attack. The risk of getting cancer actually does go up. Whether or not it goes down as much as the heart disease death rate does, we don't know for sure. But they do think some of these population studies that measure death rate actually, some of that in the operated patients is fewer cancer deaths as well. This is just a basic chart. You can go online and do this. There's all these charts with every different weight. Looks like a table of the elements, but this is just for the cutoff of 35 and 40. The only other thing I like to point out on this is you hear a lot about the 100 pounds overweight. Well, if you're a 5'0" woman, you're not 100 pounds overweight if you're diabetic with a BMI 35. So I tend to say more than 80, or depending on your frame. Don't let the 100-pound cutoff scare a friend away from thinking about this. If they're severely diabetic and have other medical problems they're worried about. All right, so now we're to the second beginning of really, what is weight loss surgery? We've been talking about obesity and risk of obesity. What is weight loss surgery? All these operations really are a tool to help control. There's sort of two parts of appetite. One is how hungry am I all the time, and how hungry am I before meals? And the second part then is how easily satisfied am I at a meal? Okay, because if you're never hungry but you nibble all day, anyhow, there's really two components. And I'll tell you, I've had a lot of patients who really say that they have never felt true satisfaction at the end of a meal. I'm luckier than that. I felt satisfaction at the end of a big meal, but the average meal did not fill me up. Well, a lot of us run out of time, we run out of money, we run out of social permission, if you will. If there's 5 pizzas in the surgeon's lounge, okay, before my surgery, I stop at 5 out of shame, because if Rick sees me take a 6th piece, and you're like, Medlin, leave some for the rest of us. You know what I mean? But we do. There are other reasons that make us stop eating sometimes than just being satisfied. I feel satisfied now at the end of a meal like I never did before. And one of the big misconceptions about surgery is that somehow or other it makes you feel sick, and so you have to stop eating. Yes, if I go eat if I way overeat, I will feel sick, I will feel bad. I've never actually thrown up, but I'll get close. I stop. Last thing I want to see is a surgeon throwing up. But way before that is satisfaction. I now wake up in the morning, instead of saying, how am I going to hold myself back from these meals, saying, I'm going to eat breakfast and feel full. Lunch, feel full. Dinner, feel full. And I'm going to have a couple snacks too. Food is no longer a stressful part of my day. It's still work. It's still the same life in different sized clothes in some ways. I still have an attraction to food that skinny people may not. But it's much more controllable. It's much less stressful. Rick?
So I forget, what controls it? Why is it that I can eat whatever I want and maybe feel full or not, but others don't feel full on the same physical volume?
And the answer to that question is that we are all different, and there are I shouldn't say a million, there are at least 30 or 40 defined mechanisms that our body uses to keep us upright. I mean, we are basically, if you look at what we do, we consume energy to live, right? And your body is very good. There are parts of your brain that are devoted to identifying food. You ever wonder how birds figure out what's food and what's not, or dogs, it's like, how do they know? But our brains are pretty sophisticated things, basically, to find food and get it in us so that we can go live the next day. But there are a lot of neurologic and hormonal controls on that process, the same as for body temperature, and there's not a single thing that you can turn on or off or adjust, but there are several hormones, and you read about them. Ghrelin is one of the biggest hunger hormones, G-H-R-E-L-I-N, that Dr. Cummings down at the University of Washington actually was instrumental in finding. You may win a Nobel one of these days over that. But so there's a lot of control mechanisms. Our gut actually is a very sophisticated sensor as to how well we've been fed, and it communicates with the brain. Some of it literally is just the speed of how that works. So if you and I sat down 5 years ago and ate the same amount of food, if I had to eat it twice as slow, the signal would get there, but it gets to me at 20 minutes as opposed to getting to you at 10 minutes. So if you stop eating at 10 minutes because you feel full, and the same amount of food made me feel full, but I didn't get the signal for another 10 minutes, guess what I did? I ate another half of the sandwich and another basket of the fries for Red Robin, right? You know? And then I got the signal and I stopped. But some people never get the signal. And this is one of the cool things to talk about for this. Weight loss surgery does have a variable degree of success. I feel very lucky right now. You know, I'm living the dream in some ways. There are some people who have weight loss surgery and they're 400 pounds and they lose 50 pounds and that is it. That's where their body wants to be. And we really have to be careful not to judge other people's journey. You know, and in terms of medical success too, a lot of what I do is education for primary care docs. One of my first patients in Duluth was a patient who had a bypass operation 20 years before. I lose track of the numbers. And she was 330 pounds, and she was smoking, and she was diabetic. I'm like, well, your bypass didn't work. Gosh darn. She had gallbladder problems. They were in the hospital for that. But I was just, you know, talking to her about it. She's like, well, I don't know. It's 400 pounds when I was 30 years old. I'm like, okay, you're now in your 50s, and you're well under 350 pounds at least. I mean, you're not living a lifestyle I would endorse. But, you know, if she hadn't had surgery, you know, she probably would have been over 500 pounds. She probably would have been dead. So be careful how you judge where somebody's weight is 5 years, 10 years out, labeling failure. And there's also, anyway, I can get on to that, but we are all different and different degrees. And science is getting some really cool stuff. I've been to 2-hour-long genetic lectures about genetic variability in some of these proteins that are formed and the way the relin responds. I think ultimately, one of these days, somebody's going to find one of these small nerve centers in our brain that control something, and we'll go into the cyber knife and we'll zap 10 cells and we'll come out and be half as hungry as we were. That's the ultimate, that would be the tool. I don't want to take a pill for life because those pills, medication goes everywhere in your body. If you could do something with a cyber knife, I guess I'm a surgeon at heart. I just want to go wisdom. That's right. There you go. Guilty. But I'll tell you also, the tool works better when you use it. And if you are exercising, then it helps for stress management. It helps for satiety. When I don't exercise for 2 days in a row, I get what I call chippy. I normally can have some chips once or twice a week, you know, baked Lays. I can make a good choice. The more stressed I get and the more unexercised I get, the more I want a big bag of Ruffles, even if I can't eat them. I just want them, you know. And so exercise helps my tool. Stress relief helps my tool. Protein helps my tool. If I start a meal, I go down to Lafines occasionally. I still live my life. I still enjoy food. But I try to have that less than once a week. And if I want something sweet, I have a protein bar, which tastes just as sweet. The chocolate, they're good. It's like a candy bar, but it's got enough protein that it's with me for the next hour and a half as opposed to being starved 45 minutes later. That's managing. That's living the same way you manage your checkbook or you manage your credit card, right? So that's learning how to live with the tool, and that is where having been through medical weight management really helps, and that's where staying engaged in a whole program helps, because surgeons kind of belong in the OR. I mean, I can do this, but nurses are so much better than me in terms of listening, because I talk too much. But that is where being engaged in a program and having a support group really helps. And so there's a lot of different impact on that tool, even making it work. I'm going to confess, this is old data. Nobody has any good new data. This is 1950s data that showed that 99% of people regained all their weight in 4 years. In the 1950s, we probably were dealing less with the epidemic obesity than the people who were probably heavy even 500 years ago. So it probably is a better number than this. But in terms of real durability, the number really does probably for most people go no more than 4 or 5 years. I've had people who've lost 60, 70, 90 pounds 2 or 3 times. Most of them within 5 years, they're back at their starting weight, or near it. But it's not good data. But this is where that many people can't just be naughty. You know, that many people can't be losing willpower. These are people who have a lot of willpower for a lot of other things. Treatment is not the same as a cure. These are tools. Like I say, I'm still metabolically a lot of the same person that I was before. Most people are. It is not a fix it and forget it thing. It is an operation that is with you for your whole life. Any of these operations. Very few people, however, even the people who really do, we occasionally run into people who their life just falls apart on, or they just, like say that some people will die smoking even if they know it's wrong, and they want to quit and they've tried 1,000 times. There are a few people, you've seen them, right, who will die smoking and they just can't stop. They from their first cigarette, they were addicted beyond all medical help, all personal help. There are a few people who probably have that degree of obesity problems too. But very few people, even when they regain some weight, ever regain it all. Any operation is not risk-free. All right, so let me pass around the band. This is a lap band. I'm not going to go. Does anybody not want to touch the band? Just wave them off. But most people don't see it. This is an actual lap band.
Yeah.
I'm sorry.
It's a new one, right?
It didn't come out of anybody. But this goes around the upper stomach. This actually, I'll just show you real quick. It goes in our laparoscopic port in kind of a straight way, and then we pass it back through to buckle it down. And then close it around the stomach. And this is out under the skin, and that's how we adjust it, this little diaphragm. It's been around in the U.S., it's actually been around for more than 20 years, but FDA approval in 2001. The diabetes only really changes as you lose weight with this. Yes, ma'am?
When I was looking into this, it seemed to me that in Georgia, I was finding physicians who had been trained in Mexico. Like they were the first. Where was it developed? Who developed
It was
it?
developed in the U.S. And Europe, but FDA approval was later coming, so it was marketed elsewhere.
Well, where was it? Was it like Europe? What was approved earlier,
It's a
and
great-
how long ago?
It's a great question, and I will try to limit my answer now to about 30 seconds, but this is a very good question.
Because that's got to be where you can get stats.
And they're stopping. They're not doing bans anymore in Europe. It was over 90% of the weight loss operations in Europe 10 years ago. It's now about 10%, because they're finding the long-term durability of this is, now, it's not that it's a bad tool, but it's not nearly as good as a gastric bypass long-term. So that's, and there are some hassles with regurgitation. There's no hormonal benefit in terms of the diabetes. The only benefit for diabetes, the diabetes part of the slide as well, is really just with the weight loss. So if you regain your weight, you don't really you lose your anti-diabetic effect. Whereas with a gastric bypass, very good question for this reason as well, Dr. Stern and I were talking about. If you take somebody, there's good new evidence out on this. We're talking about gut hormones and the way the stomach talks to the brain. The stomach also talks to the pancreas and talks to the liver. When we do a gastric bypass, we routinely see people off of almost all their insulin within 3 to 5 days of surgery. They haven't lost weight. It's changed the way their pancreas responds to messages. And so there's a weight loss, there's an anti-diabetic effect even without weight loss. And for the same number of pounds lost without surgery, you actually have more people diabetes-free with a gastric bypass. Not to say you shouldn't, if you can do the weight loss without surgery and your diabetes goes away, great. I mean, there's no safer surgery than no surgery in terms of the surgical risks. But the risk is with the diseases, if they don't go away. So, sorry, I didn't say that well. Anyhow, skip. So this is a gastric bypass, and what it basically is now, this is not any removal of any stomach. What happens here is we divide that, let me show on this a little bit. This is a model. It's a plastic model. I don't pass it around anymore because it's loved to death here, but we divide, this is your stomach, and there were things that went on here, and we basically divide that upper little egg-shaped pouch off from the stomach, and it's bigger than it looks here. It's about the size of an egg. That's not the limit of how much you can eat, but it's how much goes in that pouch. As you eat a 30-minute meal, things go through. But the lower stomach down below is disconnected, okay? So it is bypassed. Food no longer goes through that stomach. Well, once we sort of disconnect this, so they stay close together, I'm just going to hold it away. Once we disconnect this, if this is your esophagus up here, food has to go somewhere, and that's where we bring up that limb of bowel, the small bowel. We're not talking about colon here at all. So the lower, the small bowel down below, we divide it with this surgical stapler I'll show you if you want to see. And we bring that up, and we connect that to the little pouch. And you can see it a little better than I can hold it up here. But now, food goes through this valve instead of through the stomach. That's the bypass, just like a highway takes traffic around town, okay? We put things back together down below. This is the Y part of, we hear a RU and Y, gastric bypass. We put things together here down below because once we divide this bowel, all the digested juice